Welcome to the Leonard D. Schaeffer Center for Health Policy and Economics webinar series. I'm Bob Kocher, I'm your host today, and I'm pleased to moderate today's session about the future of telemedicine and how COVID-19 is going to change it and accelerate it. I'm a non-resident senior fellow at the USC Schaeffer Center for Health Policy and Economics and a member of Governor Newsom's COVID-19 testing task force and a partner at a venture capital firm called Venrock. Today's topic is a timely and interesting one. Our plan today is to have each of our awesome panelists speak briefly. We'll have some short Q&A for each of them individually, and then collectively we'll invite the audience to weigh in with questions, and we'll have a back and forth discussion. I will introduce each panelist before their remarks, but we have Leslie Saxon here today, Phil Ferguson, and Andrew Dreyfus. And so with that, I will introduce Leslie Saxon, who will kick us off. Dr. Leslie Saxon is a cardiologist and professor at the Keck School of Medicine at USC, where she's also executive director of the USC Center for Body Computing, which is a very cool sounding thing. She's a total authority on both the preclinical and clinical development of things that you can wear that can sense you, understand you, and hopefully help improve your health. She's currently focusing on medically validated wearable sensors and software to continuously monitor and assess the health and performance of warfighters in both training and operational environments to mitigate stress, increase readiness, and more. So Leslie, I turn it over to you.
Thank you very much, Bob. I appreciate the opportunity to participate today. It should be a great discussion. May I see my slides, please? So I'm the director of a center I started about 14 years ago called the Center for Body Computing. And this arose out of where I spent most of my career in implantable cardiac devices and helping develop them and get them FDA approved and show outcomes. And in about 2008, those implantable defibrillators and other devices that were life-saving became capable of network connectivity. And suddenly we could take a 60,000 device that we'd implanted and talk to it every day and get information from it. So for me, that made me realize very early on, around the same time the iPhone was being developed, on the sort of observations and healthcare outcomes you could get with connected and continuous care. So in those early days, it was really science fiction, this idea of body computing and the machine-human interface being transformative for health. And I took a lot of flack in those days for, quote, transitioning my career a little bit, but better lucky than good. So 14 years in, the Center for Body Computing really thinks of healthcare as a continuous thing, not a point visit, and as life care. Whether you're sick or well, it doesn't really matter. And we think there's a lot of discovery in between those things. So we work in clinical research showing that this vision is real and better than the status quo. We work in research, and then we also work a lot in policy. So I somehow lost my slides here, guys. Can you still see them?
Yes, we can. We're on the clinical research platform and policy legislation boxes.
Great. So you can go to the next slide. I don't know what it is, but I can still do
Leveraging the patient in their own care.
Great.
Yeah.
One of the things about medicine that's traditional medicine, I think that's a little bit of the tragedy of it, is that while have some of the best experts in the world in our country and provide acute care and other care so well, our service model is completely horrible. And anyone, even the most wealthy, have trouble navigating a traditional healthcare system. And usually there's someone trying to navigate that patient through, because it's very complex, it's very subspecialized. But at the end of the day, no one's really aligned on who the customer is because of our current payer models, and it doesn't really serve the patient, who is the end user and the customer, I think. And so I kind of view it as like the old days in the New York taxi, where it just got so bad you get in a cab and you tell them where to go. Often you couldn't even communicate with them. The cabs were bad. When I lived in San Francisco and you called a taxi, they hung up on you. And they didn't even tell you if they were coming. So I think there's a reason that Uber developed in San Francisco, because it provided efficiency and met a need. And I think that's kind of where healthcare is going, into this area called life care. I think the past century of traditional medicine, you can go to the next slide, has resulted in amazing advances, improvements in survival, cancer drug therapies, traumatic injury therapies that have been transformative. But we're kind of jailbreaking that now and jailbreaking the information that lives in subspecialist brains, because it doesn't scale into software and services. And I think the 21st century medicine is going to be continuous, as I mentioned, enabled by software and services. And for those reasons, very efficient and scalable. And the new people and companies and entities delivering that are going to be very, very different, because I don't think traditional medicine is really capable of disrupting itself, even though there may be a huge amount of lip service to telehealth in the time of COVID. And even though everybody says a clinic visit is the old dinosaur, even though for years I've known our main reason for people not showing up for cardiology appointments is parking, it's still going to be hard for traditional care to disrupt itself into this era of life care, where really a person is surrounded by software and services, whether they're sick or well, whether they're an NFL athlete, a war fighter, or someone with end-stage heart failure, trying to manage a complex disease. So we sort of look beyond that to things beyond telecare, where you don't need a doctor and a patient in the same room, or in the same on a screen. You can have a virtual human informed by AI, where you're understanding emotion, you're leveraging voice assistants, and the whole 9 yards. I think telehealth is a transition to there, and a lot's happened. A lot's happened with COVID, obviously. We'll talk more about it. That's very important. That's really all I have to say, Bob, in lead up to the discussion. Thank you.
So that's really intriguing. I have two thoughts that I bet many people have listening to you. The first one is, you mentioned about healthcare as a continuous activity, and the notion that we could body compute, and I'm doing that right now with an Oura Ring. I'm body computing and providing healthcare information to myself and others probably. How do you untangle the part of data that's sort of the daily decline that I may be making sort of as I age, versus things that are signals that are reversible that we should act on? How do you think about that data stream, and how do you disambiguate aging from things that we should intervene on?
Yeah, I mean, it's a really mature and sophisticated question, and a very realistic one, because as I mentioned, I've been doing this for 14 years. And for instance, even in my specialty, which is cardiac arrhythmias, and I've been practicing that specialty is in athletic sudden cardiac death. I am sitting on data from athletes that I've collected more continuously during football games, during other things. And sometimes when you're collecting data you've never seen before, it's very hard to know what it means, to your point. Is this data that I'm seeing a risk factor that this young, seemingly healthy athlete is going to be at risk for a tragedy like sudden cardiac death? And the truth is that you have to sit on the data for a while to understand it, even if you're an expert, because you've not seen it before. And you have to benchmark it to something you do know, like a clinical event or something else. So it really does take time, but with the scale and the amount of data we're collecting, the time to discovery is also logarithmically better. So you can make that discovery in a matter of months to years versus a generation of physicians or scientists. So that gives me hope. But to your point, it's actually very, very complicated and takes a lot of maturity and restraint. Because if you think about it, and you're suddenly collecting all this data on everyone, you could weaponize it or politicize it or use it inappropriately to disadvantage the user, which is a patient, which you'd never want to do, right? You'd never want to do that. That could be, a very terrible thing. So I'm not saying the road there is easy. It takes restraint. It's complicated. It takes traditional expertise, and then leveraging on top of that more and more data, doing the studies that show that these digital biomarkers can sit alongside ones we understand, validate them, and then be able to use them in predictive models, et cetera. So that's why we spend so much time in terms of the research part of this.
One more question for you before we jump to Hill. You gave both hope and sadness to me when you talked about how healthcare may not disrupt itself. And I've both, read many books, written many papers, and then reviewed, it seems like, just as many papers about kind of innovation and disruption in healthcare and how, it's about to happen. It hasn't changed all that much. I'm curious, when you think about the notion of kind of the continuous learning on a patient and helping a patient through that daily data improve their health and mitigate complications and live their best healthy life. That sounds really appealing as a doctor, to want to help patients do that. I imagine a lot of doctors that you talk to are drawn to that, yet we haven't done it. Do you think is it desire? Is it dollars and cents? Is it some sort of rules? Why won't healthcare build that? version of itself.
Right. I mean, look, as a physician trying to deliver care at every level of even leadership, it's incredibly hard and complicated with point visits. Also, the whole system is, the doctors have sort of lost control of the system. And when you say digital health to some doctors, they feel that the way that technology has come into medicine, which has been weaponized against doctors. Suddenly, even something like an electronic medical record, when if you really care about patient care and having all the data, having it liquid would seem amazing, right? That's largely been weaponized as a compliance tool against doctors to hurt them, put the pain on them in a lot of different ways. Whether it's meaningful use, meaningful use is one thing, but it usually cuts off the top 15% of quality physicians as well as the bottom 15. So I think we have to show people the transformative nature of this and how it can help them practice at the top of their license, when really the institutions and everything that have implemented this have kind of weaponized it against doctors and patients. I tell my patients, I will eventually look at you during a visit. That's kind of a sad thing, because that connection is really important, because I'm so, I'm a prisoner to the EMR and the computer and all the compliance mandates of that. That's not designed for excellence in patient care, right? It's designed for billing. So I'm not hopeful for it. And we never would ask a record company to disrupt itself to, single song, let the consumer choose. So why are we asking traditional medicine? The vision of virtual life care has got to come out of a completely different model. So I don't think you can ask the architects of the old one as much as it's done. And I'm a product of that. Completely, that it's going to do this next thing. I think it's going to take partnerships. Now, you need the gravitas of it. You need the evidence base. You need the training and the maturity. But most of us, particularly, highly trained subspecialists, we want to leverage our expertise out over broader groups of people. The way that our talent is in some sense being wasted it's terrible. We could be reaching many more. And at least the new generation of doctors that I train and teach do not want to practice in that way. So the most talented people want to practice in a very different way, in a digital way that reaches as many people possible. So it's all, that's all good news. I am very hopeful about all this.
Well, thank you. One of the benefits of video telemedicine is that actually I'm looking at you right now. And doctors, when they do it, can't type because they're actually talking to a patient. And patients report that they actually feel that intimacy in ways that is often better than when they're in the room and not paying attention.
Yeah, sometimes it can be very intimate. I mean, just this telehealth thing has shown me patients I've taken care of for 15 years. I'm suddenly seeing them in their home, in their habitat, and it is a very intimate sharing, thing. So it has provided some insights. I hear you. I think it definitely can meet a lot of those needs.
One of the companies I work with is a Medicare Advantage insurance company, and they actually have spoken to all of their members amid COVID to make sure they're safe. And then they've done telemedicine visits with about 40% of them. And they take the video around the house and you learn a lot. But our next panelist is the expert on this. It's Hill Ferguson. Hill Ferguson is the CEO of a company called Doctor on Demand. They're an enormous and fast growing telemedicine company. Nearly all of their healthcare is by video. Hill's been the CEO there now for several years. And he is the person you would hope would be making technology products for healthcare, because he comes from a consumer product background, having worked in a variety of really successful mobile tech companies. And Hill, I'd love to have you share with our listeners, what are you experiencing right now as a telemedicine provider in a country during a pandemic? And how do you think the world's going to evolve with COVID-19 as probably a catalyst?
Yeah, I talk a lot about it with my team. I feel like we've been in a dress rehearsal for 4 years and the lights have just come on. A lot of what we've been preparing for is really what's becoming somewhat of a normal in today's day, where all the world that we envision about having a on-demand access to a primary care provider with access to smart referrals and navigation into the brick and mortar system has happened literally over the last couple of months, but we've been building towards it for years and years. Just a quick background on Doctor on Demand. We launched our first product about 7 years ago, really as a low acuity urgent care substitute, all video. We wanted to make it an on-demand model, sort of like Uber, where you're able to see a doctor in a few minutes. And in order to do so, we had to hire physicians onto our platform. And so back in those days, you can imagine it was pretty difficult. Physicians were not really excited about taking a lot of risk. It was a very risky proposition to do so. We had to pay them more. We had to find people who were optimistic about practicing medicine in new and different ways. Nowadays, we have a line of 1,000 providers in our waiting list to come on board. So times have changed dramatically. But as part of that on-demand model and hiring physicians, we've been able to build solutions that are differentiated in the marketplace and really are trying to foster this longitudinal care idea with primary care, where patients can come back and see the same physician again and again, and really leverage the fact that these are board-certified primary care physicians who can treat 90% of what patients need. And then for that remaining 10%, we have technology and services that navigate that patient into the appropriate next point of care, whether that's a mammogram at a facility or a curbside visit or a collaborative care model with a behavioral health provider, or an in-person specialist visit. So we're just now noticing that there's a lot of interest in what we're doing. I think telehealth has gone from being an interesting, nice to have feature to now being sort of mission critical, right? And you see, we don't work in the hospital system world today, but I think every hospital system in the country has learned a lot in the last couple of months about how to practice medicine virtually. And it is becoming a strategic competency that I think more and more providers over time will be investing in and trying to figure out how to adapt to.
Hel, could you give people a sense of how the product works? So
Sure.
do you schedule appointments? Is it always on demand? Is this for emergency care? Or what are the use cases that this works best for?
Yeah, all of the above. So our urgent care offering is primarily an on-demand model. So we have physicians who are literally working 24/7, licensed in all 50 states. And the average wait time to see one of them is about 5 minutes, measured sort of an average over the year. In the spike of COVID, so going into like week 2, week 3 of March, that wait time did balloon into a couple of hours. And we had to go expand our capacity for the next week or two, got the wait time back down into below an hour, and then back to 5 minutes today where it is. For our primary care offerings, most of the patients will come back and see the same provider, but it depends on the use case. So even though if my PCP is on Doctor on Demand's platform, but I really just need a prescription refilled, I may just type in a message which goes into a care team, right? And a nurse practitioner can look at that, look at their record, and refill that prescription for them. Or they might still need to see a physician, but it's okay if they don't see their PCP. Then so that they're opting to wait less time. So Bob, if you were my PCP and you weren't set to come on shift for another few hours, I may decide as a patient, you know what, this is not critical that I talk to Bob about it. I'll talk to a different doctor and I'll wait 5 minutes. Patients vote that way about 70% of the time, and 30% of the time they're willing to wait, to see that specific provider. Obviously for behavioral health, it's 100% by appointment only. So we're providing tools to help patients match with the right provider. So patients have their own preferences around gender, race, specialty, language. And then our matching algorithm finds the right set of providers for you to choose from. And that's obviously a really critical part to that engagement because, it's going to be a recurring relationship. And so patients want to really do some window shopping, right, before they figure out who they want to work with on the behavioral health side.
Thank you. Why don't we now move to Andrew Dreyfus? Andrew Dreyfus is one of my favorite people in American healthcare because he really approaches the responsibility of a payer from the point of view of thinking about every patient as every member as if they're a family member. And has done a wonderful job at designing benefits that improve quality of care and really pushing our country into new payment models, whether it's the alternative care contract, new network designs that really focus on demanding the best quality providers being in the network. And not surprisingly, Massachusetts has been one of the leading payers in the country at thinking through how this shift towards more virtual type healthcare is going to play out. And so I'm really excited that he could join us today, and look forward to having him share some slides and then a discussion. So Andrew, to you.
Great. Can you see my slides okay?
Yes.
Great. Thanks, Bob, and thanks to the Schaeffer Center for hosting this, and to my two fellow panelists. So I want to talk about telemedicine and how we're viewing it and what's happened. Just give you a little context. Blue Cross Blue Shield of Massachusetts is a not-for-profit plan, actually chartered as a public charity, and serves about 3 million members, most in Massachusetts, but many around the country. And it's been a whirlwind. I think you all know that Massachusetts is one of the hardest hit states in the country on per capita basis. And we've really tried to adapt to that. We've sent nurses to work at the state's pop-up field hospital. We've reassigned 100 of our associates to the Massachusetts First in the Nation contact tracing effort. And we've really changed a lot of our, on a temporary basis, our benefits for our members. And a big part of that has been around telemedicine and telehealth. And I want to talk a little bit about that, but also keep in mind that I kind of view telemedicine as, in some ways, it's an important way station. I think Dr. Saxon referred to it this way too, into a new vision of health. And while she talked a lot about the personalized health, I also want to think about it as a kind of population health tool, which I think it can be if under the right kind of value framework. So here's just a little sneak peek of what some of the things we've done. So we've waived cost share for all telehealth services. We've taken down administrative barriers like prescription limits, prior authorizations, limits of out-of-network care. We're covering all cost sharing for all COVID care. But the biggest changes have really been in telehealth, and our state mandated coverage, and we had actually chosen to do it with no cost sharing and at the same rates that we pay for normal office visits for all COVID-related visits. But we went further beyond the state requirements and made that for all visits, for all care, with no cost sharing. So any visit to a primary care or a specialist. And so, no surprise, we saw this huge jump, and you can't even really see what was in February, but we had about 200 televisits claims per day, in the month of February. We had 40,000 per day in April through May. So it's just been an astonishing jump. Vast majority of those are with our local network providers, not our standalone telehealth provider, which in our case is American Well. It's mostly video visits, not phone calls, though we're covering phone calls too, as if they were office visits. And even though there's been an increase in televisits, we have seen, as across the country, the drop in elective procedures. But one interesting thing that I think we might not have expected is that the total number of office visits for mental health care have actually stayed almost constant. So you can see last April, we had almost all the visits were in office, and just a tiny fraction were through telemedicine. But now it's almost equivalent. And so this has been a mini revolution in mental health care within the larger revolution within medicine. The only place we've seen a little drop, and it's concerning, is in care for substance use disorder. That is down, and that makes us worried about deferred care and avoided care, which would be so important there. As we've heard from the other panelists, we are concerned about, do we lose that human connection in healthcare? And I think Dr. Saxon talked about a way, you both did, Bob, about how it may actually enhance that. There are obviously privacy and security issues that we have to address around HIPAA, et cetera. And we have to think about, are all clinicians trained properly? I've heard stories about clinicians who don't know how to end a televisit. They have all these kind of cues they use in the exam room about starting to get up and move towards the door. They don't know how to do it. So we sometimes live in this world where we think that clinicians, because they're so talented in other ways, are not trainable or should not be retrained. And in fact, we know that clinicians can learn to be better communicators. So what does this say about healthcare payment overall? I mean, because during the COVID crisis, we've equalized payments across telehealth and face-to-face, a step we hadn't taken before in large part because employers and consumers expect telehealth visits to be cheaper, not unlike how college students are now starting to think about demanding discounts for online learning. And so we're starting to think about what does the future of telehealth payments look like? And what those conversations are really reminding us is that it's not really a question about how do we pay for telemedicine, but how do we design payment systems for the healthcare of the future, the kind of future that Dr. Saxon talked about. Some of you know we've been a leader, as Bob mentioned in the intro, in establishing global budgets, what we had called the alternative quality contract, the most heavily studied and largest payment innovation in the country, but it's still built on a kind of fee-for-service chassis. And what we've seen in the COVID crisis is how vulnerable our medical delivery system is to the huge shifts we're seeing and how much financial pain, real financial pain, is causing, especially outpatient physician-driven care. And so we've tried to cure some of that by advancing payments to those physicians who participate in our payment model. But what we really need is to start to think more about upfront payments on a per member basis, or revenue streams that would actually be stable in the kind of pandemic we're experiencing now, and sadly we may experience again in the future. And we know that traditional fee-for-service systems don't provide probably enough incentives to support a lot of the emerging models, including telehealth, hospital at home, remote monitoring, more socially driven models of care. And so we have to start thinking about how we switch the entire model of care, and how do we think about virtual care as an important piece of that, because Dr. Saxon mentioned something, and I've heard it in a different phrase, that the kind of tyranny of the visit. And if we, that healthcare shouldn't just be about the visit, it's actually between visits that matter more than the visit itself. And so if we just replace actual visits with televisits, we won't have actually cured the larger healthcare system. So that's a few thoughts on telemedicine and our experience here in Blue Cross in Massachusetts.
Okay, that was Andrew Dreyfus, and I should have said in my effusive introduction, he is CEO and president of Blue Cross Blue Shield of Massachusetts. Andrew, I'm curious, you mentioned the tyranny of the visit, and one of the things that we are seeing is that some of those providers in the country that are capitated, have done well, because they're continuing to get the same monthly payments with much lower volume. Do you think that that's being understood and perceived by the healthcare providers that you work with in Massachusetts, such that it will draw them towards value-based models? Or are they going to actually say, forget value, this has been such an economic disaster that we need to kind of go back to our fee-for-service roots and use our market power and raise our prices? How do you think that COVID is going to affect that shift or to value-based care?
Well, I don't think we know the full answer yet, but I think the answer is both. And that's what I'm hearing so far. And I hate to overuse a phrase we use too much in healthcare, which is an inflection point. But I think there is this possibility. I actually talked to a hospital CEO today who said intellectually it makes sense to move to a more risk-based model with more guaranteed payments, whether it's on a per member per month or even global budgets for hospital. But the uncertainty that they've just experienced and that still presents itself in the future makes them be worried about risk. And so I think it's such a critical time, and this is where government payers will also play a critical role. So I think if Medicare and the large state Medicaid programs could actually lean in at this time and move towards more, I don't like to use the word capitation, but like a more fixed payment for physicians and even for hospitals, I think it would be critical. Certainly on the commercial side, we plan to do that and try to bring more stability to this very uncertain time. But I think it's an open question, and I think we need to have a debate about it. And I'm hoping we can actually move to a greater value-based payment, not away from it.
This is a question, I think, for all of the panelists. And it's one that I've been pondering for a couple months now, is we've seen this giant shift. I mean, the chart that you showed, Andrew, of 400 to 40,000, I've never seen that before in healthcare. Health change is usually measured in like things that actuaries have to see. Do you think that behaviors have been changed because people have now experienced telehealth maybe a couple times and they feel comfortable with it, such that if we did say you could choose between going to the brick and mortar place and having a tyrannical old style visit or a telehealth visit, what do we think people will choose? Like, have we changed behavior? Is this going to stick, or will we all go back to the office and figure out where to park?
Well, I mean, I'll be interested in the other panelists. I think it is going to stick. First of all, I think, barring a vaccine in the next 18 months, certainly we're all hopeful we could get it sooner, but more likely not. And barring a really effective treatment, there's going to be a fear factor to begin with. But it's interesting because I think the mental health transformation has been really fascinating as kind of a microcosm. Obviously, mental health visits are by their nature verbal, and it's very different for an ophthalmologist or ENT who really are peering into parts of our body and need that, although I understand the technology on that is going to get much better, and Dr. Saxon probably knows a lot about that. But I do think it's going to be a permanent change because I think we're changing our relationship to how we think about personal risk. And I think once you've had a few of these visits and they've been successful, it sure beats, traffic, parking, especially in urban areas where transportation is the big issue. And then just to add, there's other risks related to public transportation. So again, trying to think of this as a community resource, there's a wonderful organization in Boston called Boston Healthcare for the Homeless. And they take care of the healthcare needs of all the homeless population in the city, and it's a national model. And everyone thought they couldn't do telemedicine. Of course, their clients aren't going to do it, and wrong. They did. So a lot of FaceTime visits through Boston Healthcare for the Homeless. So I think it can be done.
How cool. Leslie Hill, what do you think?
Yeah, I mean, look, it's early days, right? But telehealth or digital health, it changes the nature of the doctor-patient relationship. It's not paternalistic anymore. It's more democratic. So when I see a patient, I need blood pressure and heart rate. So they have their Apple Watch. Not only do they have their tracing today, I've already got them doing their own vitals and their blood pressure going through HealthKit, but they show me stuff from when they were symptomatic. It's just like a diabetic. So suddenly in their own heads, because they have a dog in the fight, they're no longer passive, they're like saying, oh my God, when my blood sugar is controlled, I feel better. It's a big pain, but it's not just that I'm not going to get kidney failure or go blind. I actually feel better. So that's true for heart failure. That's true for any of these chronic conditions. So the patient starts to get acclimated to being active in their own care. And I think that'll translate into payment models too. People being willing to pay for what they see as a deliverable. Before it was just a black box. And of course, I'm not going to pay for that. It's an entitlement. But when you start to see that you're a part of it and that you're, getting direct benefit from it and you're leveraged in it and your own knowledge, and then, then doctors are like at the top of their license. I'm Captain Sully landing the plane on the Hudson. The autopilot does the rest. The patient, the automated systems, exception-based reporting. I don't care if it's an implantable, wearable, but all that stuff needs to accompany that. So cancer screening in the home, right? Your bathroom becomes your primary prevention cancer screening, your cardiac monitors, your wearables, your implantables, whatever. Patients are providing you with all that data. Yeah, they come to hospitals for operations and radiation therapy and stuff like that, but it just, that changes the culture immediately. And then they're kind of bringing you along. It becomes much more democratic. That's how I see it potentially evolving. And then who would go back from that? Because, and then you add all the other data with this computing platform, right? Oh, my geolocation, and that'll be imperative for contact tracing to get the economy back with COVID. So yeah, I need to give up a little bit of privacy and GPS and contact tracing. But if I can have confidence that that place is safe, or I can get on that bus or subway or whatever, I'll give that up. I mean, I will. I don't know if everybody else will. Data now is that maybe only 40% of people will, even in Singapore or Israel. I don't know. But that kind of acclimation to that kind of world and with health in it and being surveyed is happening, has got to happen at scale to make this really work.
Hill, you actually have the data. Are you seeing behaviors change? Like what are you seeing in people's usage?
Yeah, I mean, for the first 25 years of my career, I liked being the boss and walking in and going, boom, it's easy, you leave, right? But then you start to realize you want effectiveness, you want outcomes, It only took me 25 years to learn that, but maybe other people learn quicker. And it's not just, I put the device in, good for me, I build a lot of money, everybody loves me. But it's more like I got results from that device that I put in for heart failure. And now that patient who's on 7 medicines, maybe has a connected device, but is having a hell of a time figuring out what's going on, is actually getting the data they need to manage their disease. And the thing I put in is just a hub. It's a connected hub. So we need those for everything. And we need to connect to everyone in support of that individual. Again, if that person is seen as our customer, digitally enabled, everyone can play. Amazon, whoever, just surround them with what they need. So it's early, right? Telehealth's the first thing, but everyone's been waiting for it for 14 years. Where's that home run product for digital health or that nobody can live without? No one had it yet. No one can point to it, but now I think we can. We can say, oh, it's probably going to be 5 more things related to COVID really soon, I guess, right? I mean, you tell me, I don't know what the future of contact tracing is going to be, but it's probably important. Home testing, you know.
Hill, what are you seeing in usage patterns and behavior? Are you seeing that behavior change happen now?
Oh yeah, crazy.
Yeah.
People take so much.
Let's have Hill jump in on that one.
Go, I'm sorry, Hill, go.
No problem. I was enjoying your answers, Leslie. I think, Bob, you know, we're as humans so wired to avoid risk instinctively. And for years, we, Doctor on Demand, have been trying to help people along that adoption curve, right? And, you know, I always think of this image of a little kid sort of walking out to the end of the pier and sort of fretting over whether or not they should jump into the 2-foot drop into the lake for the first time. And finally, like, a parent just has to push them in. And I feel like we've just been pushed in, right? And I think everybody is coming up from under the surface being like, oh, that wasn't so bad, you know? And so we've always known that patients, if we could get them to try it once, would love it. And we have great NPS and great repeat utilization. I think what's been really interesting in the last couple of months is I've been going and reading a lot of message boards and Twitter and other places, listening to physicians describe their first experiences. And I've been probably more surprised with how doctors have responded to the first time saying, wow, you know, I didn't know I could do this much. Like, I was not expecting to be able to, you know, to connect or to, you know, to treat as well, or that it would be scary or different. And so I think it just speaks to, you know, how fear driven we can be at times. And we've gone past that now. I think we're definitely not returning back to where we were, but I think so much of this is how do you, to touch on what Andrew and Leslie have said earlier, if all we do here is replace the in-office visit with a virtual visit, like, that's very incremental thinking to what's possible. And in my mind, it's taking that opportunity to engage the patient in between the visits with data so that medicine can finally be what we've all wanted it to be, which is this proactive tool to engage patients, to share information with them, to have an ongoing dialogue between the doctor and the patient that is, you know, almost like a coaching type experience. It's not a paternalistic thing. It doesn't disappear until you come up with a disease, and every 3 years you come back. And I think that's what's exciting about it, because yes, telemedicine requires that you take a leap of faith to try something new. But once you go there, the opportunities are literally endless when you marry the data and the clinical expertise on both sides of that.
Probably this is for Hill, but Leslie and Andrew, you should jump in. One of the questions from the audience is about sort of the notion that medicine has been a very local experience historically, and even bordered by state borders and state licensure. But with the internet, and there's no reason why your healthcare all has to be within a mile of your house. Does that create a bunch of opportunities for better healthcare via telemedicine? Because you can connect people to people who might be more specialized or better able to build a relationship. What are your thoughts?
Well, you know, I think there's certainly that possibility, and I think that's played out obviously in rural areas already, and, you know, kind of remote ICUs. There's a lot of different applications for that. But also, I don't want to lose the fact that health is local. When we think about population health and community health, there is important interactions, and we don't want to, again, just think about the health of individuals. We also want to think about the health of populations and communities. So I think there's an argument to be made that local depth matters and local connections matter. And as we look more for social determinants of health, that's important too. So I certainly think there's some huge value, and especially in rural areas, but I don't want to make it all just kind of discontinuous care either.
Andrew,
I think I would just add to that, that I think that everyone, particularly people who get catastrophic diagnoses, cancer or whatever, subspecialty care really matters, and everyone, not just wealthy people, should be able to access the four seasons of healthcare, right? Particularly with a catastrophic illness where it's devastating for people to get the second opinion, at least, of a real expert. And the thing I don't like about more socialized system is there's this idea that you have to dumb everything down and everybody gets less good care, when everybody should be able to get the very best care all the time. Even if it's, as you said, you still need your local person caring for your disease, but the comfort that comes from knowing you talk to the MD Anderson person, everyone wants it, everyone deserves it, shouldn't be income dependent. And I don't know, Andrew, if this takes out so much cost that you can actually offer that to everybody. I'd be interested in your thoughts, if that's really like realistic.
Yeah, well, I mean, we know there's quite a lot of waste in the system, and by the way, we cause some of that waste administratively. And so there are some, I think, opportunities here, not just to look at like unnecessary care, but look at all these administrative requirements. You referenced some when you were talking about EMRs. And I hope that we can have a kind of administrative revolution while we have this clinical and technological revolution.
we have time for one more question. I have to actually go to Andrew with this one because you ran past this point in your presentation. You said, and the whole country is actually counting on you to figure this out. You said there's 100 people from Blue Cross Blue Shield of Massachusetts currently helping Massachusetts figure out contact tracing and get that set up. We in California are in the process of trying to copy Massachusetts, and we're hiring 10,000 people to try to do it. And we're just starting. I'm curious, what are your people doing and how's it going?
Yeah, it's going well. It's been interesting early on that, most of the calls that have been made, that the people being contacted only have a few contacts to give them to, but they've been receptive. The governor has been almost on a daily basis talking about the contact tracing and saying, if you get a call from the contact tracers, please answer it, because we all know we all get lots of calls that we avoid. It's emotional work. That's one of the things we've learned. It's emotional work, and people who are receiving the calls are stressed out, and they're anxious, and there's a lot of uncertainty. So training is important. A lot of our people already were working in call centers and were used to talking to people who might be stressed out. So that was another reason they're useful to start with. And we're working with Partners in Health, a private organization that has a lot of experience with contact tracing in sub-Saharan Africa and Haiti and other areas, working on other pretty scary infectious diseases. So it's off to a good start, but we still have a lot to learn. And we're going to have to obviously build this public health infrastructure all across the country.
Well, on behalf of America, thank you for lending your staff to that important effort. We all hope it works wonderfully and that you share what you've learned. And we're thankful to the people who are doing that, given the emotional intensity of that job. I want to thank Dr. Saxon, Ferguson, Andrew Dreyfus for a very engaging conversation today on a topic that couldn't be more timely. You've been listening to a Schaeffer Center Health Policy and Economics webinar series on telehealth in the era of COVID-19. And thank you very much for joining us today. And thank you to our panelists.